Actually, my screen is already shared. Right.
So good afternoon. Very warm welcome to all of you that are tuning in. This is Clinical Cases in Cardiology with Dr. David Tang. We are just going to wait a couple of minutes. I will hand you over to Dr. David in a moment. We're just going to wait a couple of minutes for people to tune in, and then we'll get started. Thanks very much.
Right, so it's been a pleasure to be invited to discuss about cardiology, knowing that in our current global situation, it's quite difficult to have didactic teaching and bedside teaching in person. And so this is a really good effort, and I applaud the coordinating team for organizing this. And so since we are waiting for more participants to join us for today's session, for those who are already dialing in, I would say that you could use the chat feature on this platform, and maybe you can key in a few questions that you want to clarify, things that you sort of never truly understood about cardiology and things that you want to clarify. And we will start at about 2 minutes past 8 in Malaysian time, or actually it's already time. So shall we begin then? Okay. So this is a disclaimer from Becoming a Doctor institution. And so basically, we will share the slides out and you can go through them at your own convenience. And so welcome from the team. And firstly, I will just list out the session outline. We will go through 2 clinical scenarios and they will have several learning points, of which I feel it will be relevant to you as an undergraduate student. And also there will be some transferable skills and basic concepts of which you will be able to apply when you start your foundation training. And of course, at the very end of a cardiology lecture session, we love to have ECG quickfires. And there will be several ECGs that we can go through and of which I hope will be of interest for you. And so let's begin with our first case. A 54-year-old gentleman attended the ED with an acute onset of chest pain. So it basically started 6 hours ago, and he described it as typically central and crushing, and the pain did not go away with GTN sprays. He has a background of diabetes and was a smoker. So when you examine him, he was diaphoretic, or in other words, sweaty and breathless. His hands were cold and clammy. Auscultations of his precordium revealed a grade 4 systolic murmur and bibasal crepitation at the lung bases. So his basic obs, we have a heart rate tachycardic, hypertensive, and the patient is also tachypnic. However, the saturation is above 94%. Note that he's on 100% oxygen via non-rebreather mask. So an emergency ECG was performed. So let's go through what are the likely ECG changes you expect to see. So as part of the interaction, it would be helpful to engage the masses if you choose the following options, and you can just type it into the chat box and we can go through it together afterwards. The first, it would be ST elevation in V1 to V3 with reciprocal changes, sinus tachycardia, right axis deviation S1 QT P3, positive voltage criteria LVH, ST elevation in lead 2, 3, AVF, and lastly, global saddle changes. So we'll give you guys a little bit of time so you can put your options down. Okay, and let's see whether we have any responses from the chat box. Right, so the answer is actually ST elevation lead 2, 3, and AVF. So for those of you who are familiar with ECG changes, I'm aware that some of you might be starting a clinical year and you might not be so familiar with ECGs. ST elevation means basically the patients have an ischemic event in V1 and V3 with reciprocal changes. So this would signify an anterior cardiac myocardial infarction. Sinus tachy right axis deviation S1QTT3 is basically quite typical of PE, but the most common ECG finding of pulmonary embolism is sinus tachy. This is just left ventricular hypertrophy, commonly seen in chronic hypertensive patients. As the elevation, this signifies that the patients have an inferior myocardial infarct. And we will go back to the scenario again and discuss about why is this case an inferior infarct. And lastly, global saddle changes, and this is typical of pericarditis. So as you can see that this gentleman has a typical cardiac history, and he has risk factors of which he is a smoker and he is also diabetic. And so when you examine him, he has a systolic murmur. So a systolic murmur can be one of two things. It could actually be a mitrostenotic murmur, or actually, my apologies, is actually an aortic stenotic murmur or a mitral regurgitant murmur. So it could be only one of two things, and the patients also have bibasal craps. So in a myocardial infarction setting, it's actually in this case where the patient had an inferior infarct. This leads to disruption of the subvalvular apparatus, the papillary muscles, and the chordae tendineae, and the patient later developed an acute mitral regurgitation, and Hans explains the murmur. So I hope that makes sense, and this actually tests several concepts and understanding in cardiology to be able to come to a conclusion. So I will start off with a picture of the heart. And starting from GCSE, many of us would be introduced to the four chambers of the heart and the great vessels. And I will come back to this picture again, telling you the importance of knowing your anatomy and why, although it sounds basic, that with our foundation knowledge about cardiac anatomy, we can slowly build up our understanding of cardiology. And so we had a case of acute coronary syndrome. It's basically an umbrella term to describe almost always a rupture of arteriosclerotic plaque. And why I say almost always is that myocardial infarction, or ACS, can display in two different types. If it's type A, it's an occlusive arteriosclerotic process. Type 2, myocardial infarction, or is actually due to global hypoperfusion, such as, for example, if the patient is in a motor vehicle accident, trauma patient losing an extensive amount of blood, they can always also present with a type 2 myocardial infarction. And in short, acute summary of ACS, we have STEMI, non-STEMI or non-ST elevation myocardial infarction, and lastly is unstable angina. And we'll go through the different features of each. So basically STEMI is consists of three different features, of which the patient has cardiac chest pain, raised trop, and also ST elevation changes. Non-STEMI is the namesake, it doesn't have ST changes. An unstable angina differs from myocardial infarction is that it doesn't have any marker of raised troponin. And why is this significant is because troponin is basically a cardiac enzyme, and it is only released in an event of myocardial necrosis. So when patient has raised troponin, it's actually an ischemic event leading to tissue necrosis. So in terms of cardiac chest pain, we will be going through each and every columns, and we'll tell you the nitty-gritty about each and every one of those. First one is cardiac chest pain. How you actually classify into typical, atypical, and non-cardiac chest pain is how many tick boxes the patient has in the history. So if the patient has substernal chest pain, quite textbook, you know, crushing in nature, spreads to the left arm, spreads to the jaw, so it ticks the first one. If the patient has a pain that is worse by exertion, for example, trying to carry groceries, walking up flights of stairs, emotional distress, and lastly, if it's relieved by GT and or rest, So if you have all three of these, the patient has a typical cardiac chest pain. And it pains me when I was doing a medical posting where I got numerous referrals from EDs to review chest pains. And eventually I realized that the patients have one of few. And the patients tend to be young, and they are in their 30s, for example, just starting yoga class, and they had chest pain that is worsened on movements. And when you examine, it hurts. So basically, it's a musculoskeletal pain. When you have this sort of structure in your mind, you're able to stratify which patient you have to pay extra attention to, because potentially it could be a cardiac event, and of which other patients you can be, slightly reassured that they are more benign disease course. And troponin is also the bane of our lives, and it is really helpful. But when you're doing a medical posting, you'll be seeing loads of referrals for trop, and we'll come to a reason why shortly. And it is sensitive, cardio-specific, and it allows stratification of risks. So for example, if a patient has high troponin on presentation with acute myocardial infarction, they tend to have poorer prognosis overall. And NICE recommends these two technologies. You don't really need to remember the companies for exams, but basically it's troponin T or troponin I. There's another troponin subunit called troponin C, but that is less well known and less used in clinical practice. So basically, troponin, in comparison to other cardiac markers that you might know of, they are slightly for historical reasons, like myoglobins and CKs, and also CKMB. These have smaller peaks compared to troponin, and they sort of tail off a bit quicker. So in comparison to troponin, it has a larger peak, and you have a higher degree of confidence in terms of seeing a dynamic change. Let's say the patient present on day 1 at 5 hours on onset of chest pain. You would have around this level of troponin rise. And if you repeat it in 3 hours, you can see a dynamic change of troponin. And this forms the basis of the NHS or the NICE recommendation for early rule-out protocols. So you take 2 serotroponins at 3 hours apart, and that would confidently help you rule out non-cardiac or non-ischemic events. So again, why I say it's the bane of our lives is that we have to babysit the patient, basically if we get referred a chest pain case, which obviously from history isn't, but we still need to repeat the troponin and stab them twice to take their blood when you're doing a medical posting. So, however, if you know that the patient has SD changes on ECG, positive cardiac history, and a raised initial troponin, do not wait for the second one, because the patient needs revascularization within the next 2 hours, and there's no point repeating and confirming a diagnosis. So this is one of the OSCE favorites, and also sometimes in medical school exams where you get asked what are the other causes of raised troponin, the non-cardiac causes. I've listed all the cardiac causes here, and you can go through at your own leisure, but the common ones would be chronic renal failure. So patients with CKD tends to have erroneously raised troponins. And if you get those in a ward setting, always try to check the patient's renal function, because that is the most common confounding factor for raised troponin. So let's move on to ECGs, as I promised. So most of you might hate ECGs for obvious reasons, but I will join cardiothoracic training next year, and this will be part and parcel of my practice. So I hope that I'm able to sort of pass on the interest for ECGs. This is basically the electrical axis of how ECG works. And there's some smart physics and electrophysics behind this, and there's no need to go through in depth for that. But I have categorized the different leads into different colors. As you can see, the chest leads or precordial leads are in the horizontal axis, as in it's in the flat axis, if I should put it that way. And also, you can see that you have V1 until V6, and this based on the position of your ECG precordial leads. In terms of the limb leads, there's derived and direct axis, and they are on a sort of a frontal plane. So you can see here AVL corresponds to the left hand, right is AVR. In AVF, we tend to remember it as foot, so it's downwards. So you can see we have lead 1 here, 2 and 3, and 2, 3 and AVF would signify inferior leads. V1 to V4 would be anterior cardiac leads, and lateral leads would be the remainders. And if I translate that into an ECG, the yellow ones would be inferior leads, the blue ones would be anterior territory, and the green ones would be the lateral territory. So if you get any ST changes, for example, in this case, we just so happen to have ST changes in anterior cardiac leads. So this is an anterior myocardial infarction. And how you would correlate that to the anatomy is that anterior myocardial infarction patients tend to have occlusion at the left main stem or the left anterior descending. If the patients have, for example, anterior lateral, yes, again, that could be high in the left main stem, or the patient could have a circumflex artery issue or occlusion leading to lateral ST elevation. And lastly, if it's inferior, most likely it's a right coronary artery disease. And there's no need to go into details about the anatomy, but the cardiologist who performs the angiography sort of have a ballpark idea about where the coronary disease will be based on the ECG changes. So now the important bit is about how you treat after you recognize an ACS. For your level, especially even as a foundation trainee, most importantly, you need to know the common pathway of treating myocardial infarction. And traditionally in medical school, you'll be taught of the acronym MONA. However, things have progressed, and there are quite a lot of controversial issues with the MONA acronym, and we'll touch about that in a moment. As you can see that I don't put oxygen here, because the new NICE guidelines on ACS does not recommend routine use of 100% oxygen actually. Although conventional to our traditional teaching is that any acutely unwell patient should be blasted with full oxygen. This my apologies for the disruption earlier. Let's go back to the presentation, and we have 2 questions actually from the crowd regarding the initial case presentation. So let's go back to the case. So the question was, why not option 1, ST changes in V1 to V3? Let me share the screen. My apologies. Okay. Right. So in this case, as V1 to V3 signifies an anterior myocardial infarction, and as I explained earlier, anterior myocardial infarction represents a left anterior descending problem or issue with occlusion, such as dissection or an arteriosclerotic plaque. And this is actually slightly postgraduate, but anterior myocardial infarction affects quite a large portion of the ventricular mass. And as a result of that, the heart will tends to have regurgitant murmurs later in life if the patient survive. Meaning the regurgitation tends to be from cardiomyopathy secondary to ischemic event, as opposed to an inferior infarct, whereby there's an acute disruption to the blood supply to the papillary muscles, and hence you get ruptures and acute myocardial infarction, actually acute mitral regurgitation, my apologies. So I hope that answers the two questions that you, both of you had. So let's go back to our slides. So basically, you need to know about the recent changes in guidelines where oxygen is no longer recommended routinely unless the patient is desaturating. And also, even opioids is actually quite controversial because there's a recent study, although not level 1 evidence, showing that concomitant use of clopidogrel and opioids such as morphines, patients have poorer outcomes. Reason being is that there is some postulated interactions of opioids with clopidogrel and hence reducing the antiplatelet activities. However, at the time of writing for this presentation slides, as I mentioned, because the evidence are not strong, we're going to continue to advocate for the use of opioids. And GTN, for obvious reason, is to dilate the coronaries, and beta blockers reduces the heart rate. And when the heart rate is reduced, there's less work for the heart, there's less oxygen need. So basically, if you remember two principles of myocardial infarction, reduce the oxygen demand and improve the oxygen delivery. And the latter can be achieved via clot busting, as we colloquially call it. So this can be any form of antiplatelets, either aspirins or the newer generations of clopidogrel family, such as prasugrel or ticagrelor. All of these are recommended by the NICE guidelines in Britain. So for the STEMI group of patients, as I mentioned earlier, these patients need immediate revascularization in the form of angioplasty, if possible. So it shouldn't be much of an issue for most parts of the UK, where patients are within vicinity of a angiography and also a cardiac cath lab. However, should you go a bit further far north, where patients, for example, in rural medicine, do not have the luxury or access to a cardiac center, where my friend used to work, she had to take a plane, a two-seater plane, and fly into the island, and where she basically provide medicine for the entire village. And so in that point, if you have fibrinolysis such as streptokinase, you can provide that as a clot busting or revascularization technique as an alternative. So, but most importantly, it has to be less than 12 hours of presentation. So the non-STEMI STEM doesn't require as aggressive of treatment, but we tend to need to prognosticate them. And the recommended scoring system is actually great. And this allows you to stratify a patient for those who are high risk requiring PCI, or those with difficult anatomies, for example, triple vessel disease, needing a CABG or an emergency coronary bypass. So for those who have higher than 3% of mortality based on Gray score in 6 months, will require angiogram within 96 hours or 4 days. Otherwise, it can be a bit longer than that. And so the rest of the anticoagulation, antithrombins are a bit of a postgraduate level, but it is of good knowledge, and you don't really need to know when and where to use each agent. So just to be aware that they are treatment options for patients who are planning for angiogram with non-STEMI. So the complications of acute MI, this is a biggie in a sense that yes, the patients tend to survive because our healthcare system has improved, and like in Great Britain, there's PCI centers where they can attain good revascularization early. But what is killing the patient afterwards are the following. And I had a medical school consultant who was nice enough to share this mnemonic when he was training for MRCP. And it's actually just a reference from Star Wars where the patient had died. They can get arrhythmias, ruptured aneurysm, so on and so forth. And Dressler syndrome, for those who are not familiar, is actually a pericarditis secondary to an acute myocardial infarction. And it tends to happen at 1 week after the initial event. So we talked about regurgitant valve earlier, and Hans, this is one way you could remember the complications of MI. Otherwise, I would always go back to this diagram, in a sense that I was taught in GCSE about the different anatomies, and later in medical schools, I add on the coronaries and the cardiac veins and the coronary sinus. And how I remember is, for example, starting from the left ventricles, you can get mural thrombi. And slowly you move out of the ventricles, you potentially get structural deformities such as ruptured papillaries, ruptured chordae. In the walls of the ventricle itself, you can get VSDs, so ventricular septal defects due to poor blood supply. You can get aneurysms of the left ventricle, so on and so forth. So everyone has their ways of remembering things like this, but these are one of the few methods that you can remember the complications for. So that's a whiz through of acute myocardial infarction, and I hope it's been clear. And here are the learning outcomes. And we have talked about the definition, the utilities of the cardiac markers, the cardiac territories on ECGs, and how you could spot quickly where are the changes, so you could know which cardiac territories is involved, and the coronaries, the management of ACS, and lastly, the complications. So let's move on to case 2. So we have a 68-year-old lady who was attending a pre-op assessment clinic. So she was waiting for a hernia repair, and she has a background of well-controlled asthma, diabetes, chronic kidney disease, and a previous TIA, of which, or TIA stands for transient ischemic attack of the brain, of which is on long-term clopidogrel. On examination, it was noted that her pulse was irregular, and her ECG reveals absent P waves and irregular QRS complices. So further questioning reveals that she's been having intermittent palpitations, and she fainted twice at home. So her recent blood test shows that she is mildly anemic. She also has reduced renal function, hyponatremic, and having normal potassium. So the question is, what is the best course of action? First recommends deferring surgery due to the new diagnoses. Initiate 2.5 milligrams BD of apixaban and diltiazem with plan for heparin bridging. 20 milligrams of rivaroxaban and bisoprolol, and refer to cardiology for cardioversion, and lastly warfarin and digoxin. So I'll give you guys some time to sort of type down your answers or any further questions you have from our presentation slides while I go through the questions that we have from the group. Right, so we will go back to one of the questions from YouTube. However, so on case 2, the answer is actually apixaban and diltiazem. We'll go back to the case scenario to make it more clear to everyone, but firstly, let's go through the options. Deferring surgery for a new diagnosis of AF, if that has not been clear to everyone, based on the ECG changes, is not necessary. Reason being AF, if it's stable and the patient is not in hemodynamic compromise, there's no reason to delay surgery. And hernia surgery, although they are elective in nature, patients who do not have hernia operations tend to present with incarcerated hernias and obstructions later in life, and an emergency operation of such actually carries a higher risk of complications and death, even intraoperatively. In terms of the option B, we have apixaban, and to those who are not familiar, is one of the NOACs, or direct, actually the new non-VKAs anticoagulants, meaning if you remember your clotting cascade, we have the intrinsic and extrinsic clotting cascade, actually both conjoins at a common pathway. And apixaban is an agent that actually directly inhibits the common pathway, or a direct 10A inhibitor, thrombin inhibitor. Diltiazem is a non-dihydropyridine calcium channel blocker. It's the same class as verapamil, if you are familiar with cardiac medications, and it stops reduces the heart rate. It is also an antihypertensive medication. Option C, you have rivaroxaban. This is the same class as apixaban. Bisoprolol is a beta blocker, a longer acting one. And cardioversion, we will talk about later. Warfarin is a very traditional drug that is used in anticoagulation. And digoxin as well is a very archaic medicine, also discovered in Britain, for example, as a historical fact, with the plan for heparin bridging. So digoxin plays the role as rate control, warfarin as anticoagulation. Why apixaban? So if we go back to case, the patient has poor renal function. So if you have poor renal function, rivaroxaban is actually not an option. But why warfarin? It's actually because apixaban is easier for the patient. There's no INR blood tests. If you start patient on warfarin, they need to come to clinic often, and they need to get their blood tests checked. And on top of that, they need to be on strict diet, whereby they cannot increase their vitamin K intake unknowingly. For example, eating too much kale, that actually deranged the INR. So apixaban is a good option for an old lady who is going for surgery. And it's easy to bridge and stop as well. In terms of rate control, you should see here that the patients have intermittent palpitations and fainted twice, meaning the patient actually has symptoms. Symptomatic AF should be treated. And in our options, we have diltiazem and bisoprolol. And why we went for diltiazem is that bisoprolol, if you remember, one of the side effects is exacerbation of asthma. And just so happened that the patient also has asthma as an underlying background. And these are the other other comorbidities which increases the patient's score for risk of thromboembolic events. So let's quickly move back to this case, where we had a question about what happens afterwards if the patient presents more than 12 hours and can't do streptokinase for the patient. So basically, those patients who presented late are not a candidate for either angio or streptokinase. We manage them expectantly, meaning we give them all the evidence-based medications like beta blockers, GTNs, aspirin, clopidogrel, in hoping that the patient will have the best outcome at the moment. And also, for those patients, we manage their symptoms. For example, if they start developing complications, we manage that. And there's no actually role for revascularization anymore. So I hope that answers the question. And so we can go back to the atrial fibrillation case. So in terms of a little background about AF, it's actually independently associated with mortality in men and women. And also in terms of anticoagulation, we can see that reducing the coagulopathy of the patient reduces the stroke and mortality rate in patients. And 1.5% of the patients tend to have stroke, even on anticoagulation. actually, my apologies, its average stroke rate is actually 1.5%, and the death rate is around 3%, even in anticoagulated patients. And lastly is that some patients who have AF in younger population, or they start developing AF at an earlier stage, we always think about inherited cardiac conditions such as cardiomyopathies and channelopathies. And so how we classify AF is by the duration of onset. So if it's less than 7 days, it's called paroxysmal AF, but it tends to typically resolve on its own. And the classic history is that the patient get palpitation, for example, when they are traveling on the tube or on the bus, and that resolves spontaneously. And it's hard to catch on ECGs because of the transient nature of paroxysmal AF. For persistent AF, it lasts more than 7 days. Long-standing AF are the ones that last up to 12 months with or without cardioversions. And permanent AF are the ones that we as clinicians and patients have come to sort of an agreement that the patient no longer requires cardioversion as the success rate is. Okay. So the causes of AF tends to be quite useful in clinical setting and exam setting as well. And I sort of roughly listed it in a sequence of how common it presents. But on your placements or when you start as foundation trainees, you tend to see a lot of sepsis and a lot of inflammation. For example, patients who are undergoing surgeries, patients who are in because of, for example, exacerbation of their well-controlled lupus. These patients can develop AF. Advancing age. Almost 8% of patients above the age of 80 get AF, and this is just from the fibrosing of the cardiac muscles. And they might not have any underlying cardiac disease, hypertension, or diabetes to predispose them to have AF. So age on its own is a risk factor. Ischemia, as we've spoken earlier, can lead to fibrosis and naturally would lead to AF if in long term. Alcohol and drug use is prevalent in most part of London and also a greater part of Britain. And patients like those we see quite often develop AF. Respiratory events, and what I meant by that includes pulmonary embolism, pneumonia, and some other disease processes in the lungs that are not related to cardiac issues. Hemodynamic stress tests, for example, if the patients have valvulopathy, they get dilation of their left atrium, and as a result of that, they can also develop AF. CKD, as I mentioned earlier, is quite linked in cardiac diseases and endocrine disorders such as patients having hyperthyroid, patients having pheochromocytomas, those kind of endocrinopathy, patient can get AF as well. And although it's not an exhaustive list, these are the common ones that you tend to see. CHAPVAS scoring and HASBAT scoring. Why do you need to risk score? As we mentioned earlier, is that we need to anticoagulate and we need to decide which patients actually benefit from anticoagulation. This is actually stratified based on these two scoring systems. I've taken this out of liberty from MedCalc. Reason being is that when I was a practicing foundation trainee, on the phone with the hematologist, the best friend of yours would be this app, where you could easily key in all the different risk factors that a patient has, and it will automatically calculate the scoring system and tells you the percentage of risk the patient will develop thromboembolism. So it's actually quite useful. However, in your stage, you might need to remember the components of each stage, because in an MCQ exams or single best answers, you might be given a case scenarios and asked to decide on anticoagulation. And CHAPVAS scoring should be one of those things that you have in the repertoire of risk scoring systems at the back of your mind. HASBLAT compares the bleeding risk and is conveniently named as such. So CHAPVAS scoring, for example, in our case scenario, the patient has a score of 5. So she is at risk of having stroke, TIA, and thromboembolism at around 10%, and risk of ischemic stroke at 7.2%. And anything above 2, we definitely need to anticoagulate. Okay, and so we have a question from the, give me one moment. We have a question from one of the attendees saying that Nye says that for acute presentation of AF, you can either cardiovert electrically or use pharmacological cardioversion or give rate control. Okay, so we will go into management of this in a moment, and we'll cover that. In terms of AF treatment, I think it's useful to clarify from the beginning where we have 2 stems of treatment. One is anticoagulating, and another one is actually treating the symptoms. Anticoagulating prevents them from getting thromboembolic events. And this is not just stroke prevention, because you will hear a lot of clinicians loving the word stroke prevention. Stroke is major, but some patients tend to get embolism into the mesentery, get embolism into the distal limb, and they can lead to gangrenous toes and things like that. So those are also thromboembolic events, of which I believe is a better umbrella term to describe the sequelae of AF. The other stem of treatment is to treat the symptoms, and this could be rate control, rhythm control, and we'll come to that in a moment. So we anticoagulate in AF is because of these evolutionary sort of useless portion of the left atrium. Not many of us has the luxury to look into someone's heart, but this is actually adapted from a surgical atlas. And as you can see, the left atrial appendage is actually an extension of the left atrium, and it doesn't serve any purpose other than being an evolutionary rudimentary organ. So if you get fibrillation of your heart where the blood is not efficiently removed from the left atrium, pulling off blood in the left atrial appendage, as you can see, which occurs in quite a big capacity, can lead to clots formation. So this is why we anticoagulate patients. And the choice of anticoagulation is based on this guideline, of which I've adapted from the European Society of Cardiology. If you choose a NOAC, it should be catered to the patient in terms of their comorbidities. Rivaroxaban and apixaban are very commonly used these days. Reason being that rivaroxaban and apixaban trumps our traditional warfarin is that one, it doesn't require INR monitoring, and secondly, it doesn't require any dietary changes. Rivaroxaban is a once daily dosing, and if you remember pharmacology, the reason that you only need to dose the patient once a day is because it has longer half-lives. As a result, patients with renal failure, we tend to like the twice daily dosing of apixaban instead. And in terms of the warfarin anticoagulation, it still has a role to play, whereby we tend to use them in structural heart diseases, those with valves, and the following impairments as well. Why, you might ask so, is that warfarin is tried and tested, and it goes as old as digoxin and traditional medicine. However, the NOACs are relatively new. They have been in the market for 10, 15 years, and there's no evidence of their use and safety in the following disease processes. And as a result, we're still using warfarin for the patients with disease processes in the column on the right. So now we go to the crux of symptomatic AF. If the patient is asymptomatic, basically, if you detail the NICE guidelines in the sense that you go through each decision tree, NICE recommends going for rate control first. There's several reasons for that. It's because one of which is that the rate control medications tend to be of less, in terms of less side effect profile. You have less side effect when you give patient rate control. Secondly, is that there are higher success rate in terms of introducing rate control, because like I said, advancing age is one of the risk factors for developing AF. And also, if the patient has long-term AF, for example, if time has left, for example, a year since the diagnosis till treatment, the success rate of rhythm control is really low. So it gets exponentially lower as the disease duration progress. Rate control here, we just need acceptable rate. For example, within the range of 60 to 90, it's fine. There's no definitive range of rate control, but as long as the patient remains asymptomatic, we're happy. And in terms of rhythm control, we tend to favor it in younger patients, those with paroxysmal AF or new onset of AF. And new is a really arbitrary word, but is actually less than 48 hours if you want to stick to guidelines strictly. But in clinical practice, it is really hard to know when the patient actually had AF. By the time you see an ECG change, it could be months, it could be weeks, and patient might not even have symptoms. So it's quite difficult to use the less than 2 days time limit, of which might be useful if the patient is admitted into the ward, initially have normal ECGs, and when the patient, for example, started developing symptoms, you repeated the ECG and you showed a new change. That might be the only situation where you could pick this up. If the patient failed rate control, NICE also recommends going for rhythm control. However, if the patient is hemodynamically unstable, hypotensive, tachycardic, losing consciousness, you do electrical cardioversion straight away. Do not wait. Do not think about anticoagulation. Do not think about anything else. Okay, so that goes to your ABCDE resuscitation protocol. So for rhythm control, basically this is a postgraduate level. In terms of the choice of medication, I've inserted it here in case some of you might be interested in knowing a bit more about the treatment guidelines. If the patient decided to go for cardioversion, and we know exactly when the AF has started and it's less than 48 hours, we can electrically cardiovert. So if it has been more than 48 hours and there's a higher risk of having clots in the left atrial appendix, we will anticoagulate the patient for 3 weeks, and then we electrically cardiovert the patient. In some other conditions where we need to convert the patient using medications, the following decision tree will significantly decide on which treatment outcome is the best. In terms of rate control, we've spoken about the different choices, such as non-dihydropyridine calcium channel blockers, or beta blockers, and digoxin, each of which has its own side effects. Beta blockers are contraindicated in asthma, or relatively contraindicated. Non-dihydropyridine calcium channel blockers are contraindicated in heart failure, and digoxin is contraindicated in chronic renal failure. So this decision tree basically just helps you decide based on each side effect profile and also the patient comorbidity, and allows you to come to a decision of which rate control agent is the most suitable. And that basically summarizes our learning outcomes for AF. And the reason I chose these two clinical scenarios is that they are by far and wide the most common cardiac presentations, alongside hypertension and also hypercholesterolemia and heart failure. However, with the time constraint and we're trying to keep to our time limit, I've chosen these two because they are exam favorites and you tend to get a lot of questions from these two main topics. Last but not least, since we have 10 minutes to spare, we're going to go through some ECG spot diagnosis. This is not to be a standalone ECG sort of tutorial, but we have we'll go through some basic rules where you will interpret the ECG based on the rate, rhythm, axis, PQRST complexes, the obvious abnormalities and the cardiac territories, the rate, whether it's tachy or brady, whether there's any P wave. If there's no P wave, most likely it's a flutter or atrial fibrillation, and looking at the QRS complexes, whether it's a supraventricular or a ventricular complex. Okay, so it's meant to be something fun. I'm going to fire through ECGs and we'll go through each and every one of them. So first thing first, so just to pique your interest, I'm going to give you 5 seconds. 5, 4, 3, 2, 1. So basically, as simple as this one to start with is a normal ECG. We can talk about some basic principles of interpreting a normal ECG. Is that it's really good for calculating heart rate. As you can see, there are roughly around 3 major big boxes here. If you divide that by 300, the heart rate is around 100 beats per minute. And you can see that the rhythm is regular and the axis is interpreted by the highest positive deflection. So this is a positive deflection and this is a negative deflection. So lead 3 has negative deflection, positive deflection. If you see the most tallest ECG positive deflection is actually shown here in lead 1. So this is a normal axis ECG, and any axis in between AVL to AVF in terms of the frontal plane is actually a normal axis. And looking at all the QRS complexes, it's normal. Right, so let's start with our first challenge. So shall we get some responses from the crowd? And let's see whether anyone can get the answer for this one. So if I give you guys a hint, we can see ST changes, and this is evident in the anterior territories. We can see it in the lateral territories as well, and we can see it in the inferior territories. Yes, so excellent. And I apologize for less than 5 seconds for ECG interpretation. Reason being is that the first one was a normal ECG and hence we went a bit faster. But for this one, as you can see, it's a pericarditis and excellent. It's evidenced by saddle shape as the elevation. And there's no territories that sort of demarcate where the ischemia is. So it is a global ST as changes, saddle changes. So it's a classical presentation of pericarditis. Next, we have another ECG, and this is rather interesting because there's a few learning points. So anyone wants to give it a try? So you can just write your responses down in the chat box and we will pick it up. Okay, so I can see someone typing. So someone suggested that this could be an atrial flutter. So I would try to sort of explain why this is not an atrial flutter, because you can see P waves. If you move your eye all the way down to lead 2 at the bottom, the long lead 2, you can see that there's a P waves presiding every single QRS complexes. So to quench your thirst, actually someone else is 2 P waves. Right, so that is actually not another P wave. We will go through this again. Basically, just to quench your thirst in terms of what this ECG is about, you can see alternating tall and short QRS complexes. And each short QRS complexes, in front of it, you also get a P waves. And hence, this is not a flutter. And what this is actually a massive pericardial effusion. And you noted that I used the word massive. Reason being is that the pathophysiology of this ECG is that heart is encased in its own sac. And in that sac, it meant to have some lubricant fluid. But in pericardial effusion, where the fluid is excessive, the heart sort of pumps in a small water balloon. And when it pumps in a water balloon, it will sort of swing on its own axis. And so you will get a glimpse of the leads being close to your chest leads, and hence the QRS complices are high, and you get glimpses of the heart swinging away from you. So the QRS complices will be low. Basically, this is a massive pericardial effusion, and you might not be wrong to say that this is a cardiac tamponade as well. And to tie it into a clinical scenario, we can know if definitively if it's a tamponade, if the patient is hypertensive, and what sort and what not, if the patient is in hemodynamic instability. Next one. Right, give it a try. So think about the P waves, whether there's any presence of P waves. Think about the width of the QRS complices. How wide is the QRS? So we'll give you guys some time to write down your answers. And if you have any questions, I'm more than happy to clarify in terms of your ECG doubts. Right, so basically I would describe this as a polymorphic ventricular tachycardia. So as you can see, this QRS complices here are wide, and when we describe QRS complices as wide, they are basically more than 3 small squares or 120 milliseconds. If you speak to some cardiologists, they will be really annoyed when you describe ECGs in squares, but they are 120 milliseconds for each small square, 3 small squares. And this is wide, and hence the complices, depolarization comes from the ventricle, and they are fast, and so they are tachycardias. And lastly, they are polymorphic. So polymorphic, they differ from VTs actually. So VTs, they are tall waves, but they are actually of the same height. So as you can see here, there are differences in height. Some are taller and some are shorter. And we have an answer from the crowd, and it's actually Torsade du Poids. Okay? It's due to low magnesium or electrolyte disturbances in the body, commonly seen after cardiac surgeries or patients who are on treatments, psychiatric medications. And how it differs from VT and VFs is that if you take a portion of the ECG, for example, on lead 2, if you look at the baseline, the initial portions actually look like VFs because it's fibrillating. But it doesn't look like VT because it's polymorphic. Okay. We have a question from the crowd. What does a normal ECG look like? And so let's go back to the normal ECG, and this is the normal ECG. So some of you might not have done clinical work, and you're not sort of experienced at looking at ECGs, and I apologize, this is not a dedicated lecture on talking about ECGs, but it's just for fun that we go through some interesting cases. As you can see, normal ECGs, the QRS complices are narrow. There's P waves in front of each QRS complices, and there's a T wave afterwards. Okay, I hope that's sort of the imprint that you should have in your mind, and so you know how to compare normal versus abnormal like this one. Let's move on to the next one. Okay, anyone want to give it a try? Let's get some answers from the crowd. Excellent. So first time's the charm. So we have someone saying that this is hyperkalemia. And so for those who have not come to a conclusion of why this is hyperkalemia, is that we have tall tented T waves, best seen in V2, V3, wide QRS complices, and absent P waves. Okay. So how I remember changes of hyperkalemia is basically if you use your finger, try to pinch on the T waves and pull it up. If you pull up the P waves, you're going to get tall tented P waves. The QRS is going to be pulled wider, and the P waves will be flattened because you're pulling on the other tail end. So I hope that's a nifty way to remember the changes for hyperkalemia. Right, let's move on. So what do we have here? We were quite biased towards tachyarrhythmias, all having heart rate above 100. So this one has the heart rate less than 60. We have the bradyarrhythmia. So let's hear from the crowd in terms of what sort of presentation we are being faced with. Okay, so while you guys are interpreting the ECG, I have a question on whether gastritis attack, inflammation of the gastric antrum, disturbed the result of an ECG. Well, I would say no in most cases, but yes if the patient is rolling in pain and could not cooperate. If the patient can't cooperate and kept shivering in pain, of which is a rarity for gastritis, you might get artifacts on ECGs. Okay? But I would tell you what gastrointestinal pathology would affect your ECG, and that would be a hiatal hernia. And for those of you who have not heard of hiatal hernia, your diaphragm is meant to be a sheet of muscles, and you have several holes of which important structures pass through, such as your aorta, your vena cava, and your esophagus. And hiatal hernia, you get your gastric fundus being pulled up into the chest, and basically patient tends to have gastric portions of the anatomy in their heart or behind their heart. And so that will give you left axis deviations that will affect all your ECG changes. Okay, but definitely not gastritis in the typical sense. So another question is whether VF is polymorphic or monomorphic. VF is polymorphic, but it's different from ventricular tachycardia or polymorphic ventricular tachycardia. In terms of VF, it's quite distinctive. I don't have a picture here, but if you just Google in VF and side by side you Google in ventricular tachycardia, you will see stark difference between the both ECG changes. Ventricular fibrillation are fibrillating weak sort of baseline. Ventricular tachycardias are massive, powerful changes in QRS. So if you're a Pokemon fan, ventricular fibrillation would be a Magikarp and VT would be a Gyarados, if that makes sense. Okay. You can Google it now and you will definitely see the difference, and you'll be able to tell the next time you see another one. Right, so we have some answers here stating that this is a right bundle branch block or this is a first degree heart block. You guys are in the right ballpark in a sense that both right bundle branch and first degree heart block causes bradyarrhythmias. But this is taking another step above it. If you go to lead, long lead 2, and this is the best lead to look at rhythms, this is definitely a bradycardia. But as you can see here, we have a dissociation of P waves and the QRS complices. So I can't really show my pointer here. Actually, I can give it a try. Okay, so you can see here, we have a P wave, followed by another P wave, followed by another P wave. And the QRS is here, and here, and here. So both of them are dissociated and they have their own rhythm. And the effective heart rate, the one that is generating your pulse or your ejection fraction, is the ventricular depolarization. So this is a third degree heart block, okay? And your rate is actually determined by the QRS complices. And this one, we have 1, 2, 3, 4, 5. 5 small squares divided by 300 divided by that, so the heart rate is around 60. Okay. Last but not least, I shall pose a challenge that I have been provided when I was a medical student, when I was doing a prize exam for cardiology at Barts. So this is a fun one. So let's hear from the crowd. Okay, so I have another question on how to differentiate VF and torsade. Torsade have QRS complices that are slightly taller than VFs. Although they are polymorphic, but torsade du poids have QRS complices that are taller and they are variating. So you have tall complices followed by wiggly baselines. Ventricular fibrillation is just a wiggly baseline all throughout. Okay. Right. So shall we hear from the crowd? What sort of ECG are we being posed with? So this is definitely a fast ECG. In fact, one might argue that if you haven't seen a VT before, this looks very much like a VT. But so someone has posted saying this is SVT. It actually isn't, because you can see wide QRS complices. So it's more towards the ventricular side rather than supraventricular. So if it's SVT, you will see complices like these ones, if you can see my red pointers, and they will be really close together. Right. So to end your misery, and this is meant to be difficult because I got this in a prize exam, and we are meant to write an essay on this ECG. This is an so let's go through the ECG. We can see ventricular complices here, and they are tall and fast. And afterwards, we had a portion of slow heart rate. However, it's actually irregular. So what can you tell by that? This is actually an atrial fibrillation with a rapid ventricular uptake. And by no means you're expected to know this for your final exams, but it's just fun to know. So when you have atrial fibrillation, the atrium is fibrillating like ventricular fibrillation. So the heart rate is fast. But what's stopping normal VAF from conducting all those fast depolarizations down into the ventricles are your atrial ventricular nodes, and also your Purkinje fibers and your bundle of His. So those will stop the complices from being pushed all the way down. But in this case, can you see that there's a little bit of a upward slope? That is what we call a delta wave. And this is seen in Wolff-Parkinson-White syndrome. And it means that in the heart, which is meant to be a circuit, actually has an abnormal connection at one place where the electrical circuit can escape from atrium to ventricle. If you look at the heart, it should be very systematic. The ventricle, the atrial depolarization starts from the SA node, spreads throughout the atrium, goes to the AV node, the bundle of His, the Purkinje fibers, and spreads all around the ventricles. But here we have an accessory channel. So the AF autonomous pulses escapes from the accessory channels, goes into a loop, and it causes fast ventricular uptake. Right, so cool. So this is what we have for all our ECGs. And takeaway messages is that from our session, we need to know the salient features of acute coronary syndromes. What's the use of troponin in terms of detecting and also prognosticate acute coronary syndromes. We do not wait or do not sit on the STEMI, and we need to revascularize them as quick as possible. And VTE prevention in AF is paramount because not just we want to prevent stroke, we want to avoid mesenteric complications like embolism, we want to avoid gangrenous limb, we want to avoid systemic or pulmonary embolism. Last but not least, enjoy reading ECGs. It's a good skill to pick up, and it comes with a lot of practice. And when you're at home, when you have nothing much to do, you can always Google a picture up and compare it with normal ECGs. And that is how you can develop your skills to do spot diagnoses. Otherwise, you can go systematically via your rate rhythm axis and your PQRST. Right, so we have another questions on how AF and bundle branch pattern look like. So AF itself will will actually display as absent P waves, and you get irregular QRS complexes. So that's one. And bundle branch blocked, you get widened QRS, you get the typical W changes in V1 and M changes in V6, and you get right axis deviation. So that's how you would look like. Unfortunately, I don't have it in a slide here to show you, but that's pretty much how you will see AF and bundle branch block. The question isn't specifically towards right bundle branch, it's just bundle branch in general. But basically in bundle branch pattern, you will get widened QRS. The reason being is from bundled His down to Purkinje fibers, it should be a straightforward highway for electrical conduction. But when you have a bundle branch block, there's a delay, and hence you get widening. Make sense? Okay. Right, so that's pretty much it. Thank you for today, and I've included all the answers to the ECG spot diagnosis. So if you were to go back to the slides again to give it a try, you have the answers to refer. Okay, so that's pretty much it for our session today. Thank you very much for tuning in, and I'm happy to take any questions, final questions really, because we are running out of time. So we have bundle branch block. So the question is, how would patient with AF and bundle branch block present clinically? So AF basically doesn't always become symptomatic. And yes, with bundle branch block, some patients might have symptoms, but you need to know in right bundle branch block, it's actually a rather benign disease process, and patients don't get symptoms. In left bundle branch block pattern, yes, they might not have any symptoms as well, but they are markers of a previous infarction or a previous ischemic event. So when you see a left bundle branch pattern or left bundle branch block, which is new, always think about a recent ischemic event. Okay. So I have a question on someone wanting to do cardiology and whether I have any advice on how to pursue cardiology. Just a disclaimer, I'm a surgical trainee going into cardiothoracic surgery, so my advice might not be the most up-to-date. But in general, in Britain, if you are training in the UK, it's 2 years of foundation training, 3 years of integrated medical training, which includes a year in ICU, and afterwards you go into your SD training, which is directly doing cardiology work and clinical training. So all in all, you have 2 different interviews to attend. One for your integrated medical training, and the second one for your SD or registrar training. And lastly, if you decide to go on a fellowship, you will have another interview for that as well. And most of you might wonder cardiologies and what are the subspecialties you can go into. Ischemic heart diseases tends to fall in the realm of interventional cardiology, meaning they are cardiologists who do catheter-based interventions, such as angiographies, they do stenting of the coronaries, they do TAVIs or transaortic valvular implants, things like that. Secondly, you can go to heart failure medicine. They are consultants or cardiologists who are specialists in dealing with the heart failure issues, such as heart failure with reduced or preserved ejection fractions, and some patients who require palliation from their symptoms, and how they choose patients who are suitable for ventricular assist device and refer to the surgeons for the implants. And they are also leading transplant teams. You could also go into congenital heart disease, and there's an upcoming realm of grown-up congenital heart disease, because back then, where congenital heart disease used to be a fatal disease, we have a population and a cohort of patients who survived their childhood congenital issues and now have becoming adults needing special care. And this this clinical work would involve working with pregnant women who also has congenital heart disease and surgeries in the past, and how to optimize the condition, and also thinking about second surgeries and prophylactic surgeries. And lastly, we have electrophysiology, and that is basically a specialty where you look at ECGs all day, every day, and you will be doing interventions to correct electrical rhythm. Okay. So that's brilliant. Thank you everyone for being very cooperative and interactive throughout the session. I am happy to take any questions via my email, and I'm sure you could get it from Becoming a Doctor, and they are able to share my email with you, and you can just write me anything about cardiology or about medicine in general. I'll be more than happy to get back to you. So thank you so much for tuning in, and we are happy and glad to have you guys. Okay, that's brilliant.